Use the role of a DIS with presenters Danielle Ulmer and Amanda Reich. My name is Jordan Murch, and I will be moderating this session today. As a reminder, please remain muted throughout the presentation. You may put your questions in the chat at any point during the presentation, and we encourage you to do so, but we will save all questions until the Q&A portion at the end of the session. Now I'd like to introduce your presenters for today. Danielle Ulmer is a public health follow-up consultant for the STD Prevention and Partner Services Program at the Texas Department of State Health Services, where she holds contracts for San Antonio, El Paso, Public Health Regions 8, 9, and 10. While at DSHS, Danielle has worked on STD surveillance efforts and database migration, contract management, congenital syphilis, and PrEP initiatives. She has trained new DIS in the Texas fundamentals of STD interventions, and she has created and hosted trainings for Texas frontline supervisors. Danielle is a graduate of Temple University and worked as a disease intervention specialist in both Philadelphia and Austin, Texas, prior to joining DSHS. Danielle has previously worked on special projects such as the Cooperative Agreement Re-Engagement Controlled Trial by the AIDS Activities Coordinating Office of Philadelphia, DIS Rapid Response Deployment while at Austin Public Health, and COVID contact tracing at the Texas Department of State Health Services. Amanda Reich began working for the Texas Department of State Health Services as a public health follow-up consultant, providing guidance to several programs across the state, reviewing statewide congenital syphilis case records, and conducting database conversion in 2017. She currently works with DSHS as the Congenital Syphilis Coordinator, providing guidance and technical assistance to partner services programs across the state regarding congenital syphilis reporting, facilitating, and moderating fetal infant morbidity review boards on congenital syphilis in Harris, Bexar, and Dallas counties. In addition, Amanda writes the Texas Congenital Syphilis Program Operating Procedures and Standards and currently serves as the co-chair on the National Coalition of STD Directors Program Committee. And with that, I will now hand it over to Danielle.
Thank you so much, Jordan, for that warm introduction. And today we will be talking about disease intervention specialists' role in STI prevention among clients engaging in substance use. And our intention today is for you all to walk away from this presentation with a better understanding of the national trends of substance use among persons diagnosed with sexually transmitted infections, specifically syphilis, how to conduct partner services with clients who engage in substance use, how substance use impacts maternal and congenital syphilis, and how the social determinants of health affect client care, and some strategies for harm reduction. So the data presented is the most recently available national data collected by the DIS and analyzed and presented by the CDC. So we're going to talk about STI and substance use trends across the United States, specifically from 2014 to 2018. And this slide you'll see reappear throughout the session. This is our reminder of why we're doing the work. And it is imperative to detect disease when and where it happens. So we're going to take a look at the data itself. So what you're seeing here are reported rates of primary and secondary syphilis in the United States, broken up by region. And again, this is within the past 10 years. And remember, this graph is not broken down by race, ethnicity, or gender. So let's take a closer look. Let's look at all the syphilis cases over the past 5 years from 2014 to 2018. You'll notice on the left, you're seeing cases, and on the right, you're going to see case rates. So in 2018, the rates for Texas were 45.8. For Wisconsin, it was 8.8, and the national rate was 35.3. So if you notice, the past 5 years, Texas's rate has been higher than the national rate between 2014 and 2018. So we see syphilis has been increasing over the past 5 years. So let's start looking at some supplemental information. Let's break this down even further. So this is a reported drug use among women with primary and secondary syphilis in the United States from 2014 to 2018. Amanda's going to talk about this graph in more detail later on in the presentation, but just notice here the dramatic rise in substance use among women. And here we're looking at reported drug use among men that have sex with women with primary and secondary syphilis from 2014 to 2018. And just note that the reason that the sex with person who injects drugs, the PWID, is on here is because it is indicative of the person's social network. We recognize that it does not necessarily reflect the individual's substance use behaviors. So you'll notice with injection drug use, there was an increase from 3.7% to 7.7%. That's a 100% increase. Methamphetamine use was also 100% increase. Heroin use did increase from 1.8% to 4.3%. That's a 139% increase. And then reporting sex with persons who inject drugs did increase from 5.8% to 9.8%. Again, that's not something that we're necessarily diving into today. So when we look at reported drug use among men that have sex with men diagnosed with primary and secondary syphilis in the United States from 2014 to 2018, we want to note that, number one, meth is the most commonly used substance among the MSM community, but most of the rates in these graphs are stable. So just keep that in mind. We're going to see the same pattern throughout this presentation. So let's review this as a whole. We have an increase in reported injection drug use for men that have sex with women and women. We have an increase in the U.S. in methamphetamine use for men that have sex with women and women. We have an increase in heroin use for men that have sex with men that have sex with women and women. And we have an increase in sex with a person who injects drugs for men that have sex with women and women. So now what we're going to do is we're going to look at substance use by region. And let's go ahead and we're going to start with methamphetamine, mostly because meth was the substance with the highest prevalence throughout these graphs. So right now, what we're looking at in this graph is reported methamphetamine use among women diagnosed with primary and secondary syphilis. So again, Amanda will talk about this, but notice how the rates are increasing, or the percentages are increasing. And now let's talk about methamphetamine use with men that have sex with women. So we are noticing an increase in all regions. Let's take a look at the Midwest. We went from 2.4% to 14.3%. That's a 496% increase. And now if you look at the South, you have a 3% increase to a 7.9% increase. That's a 163.33% increase. And then when we take a look at MSM reporting methamphetamine use who are diagnosed with primary and secondary syphilis, again, rates primarily stable over the last 5 years. And, you know, it is noteworthy because syphilis cases are still primarily among men that have sex with men. So why are we seeing these huge increases in men that have sex with women, and we're seeing these stable and low counts of drug use among men that have sex with men? So let's compare the two regions, because that's what we're really focused on today. Us coming from Texas, and we're doing this, your STI conference in Wisconsin. Let's compare the two. So in the Midwest, we're seeing an increase in methamphetamine use among men that have sex with women and women. And in the South, we're also seeing that same trend, but we're seeing a slight increase in methamphetamine use among men that have sex with men. So let's go to the polls. So how do people use meth in your jurisdiction? Do they inject? Do they smoke? Do they snort? Do they use suppositories? Do they swallow? Or is there some other use? And it looks like we're getting some questions, we're getting some answers here. And just for fun, let's talk about some commonly used names. Some of you might hear in your interview: crank, crystal, glass, ice, speed, Tina. These all might be words that your clients are using during the interview as well. Looks like 50% still need to vote. Okay. It looks like injecting and smoking are our highest use of meth in your areas. So let's go ahead and move on. Let's switch from methamphetamine, which is a stimulant, to another drug, which is completely different. We got heroin, which gives us a completely different feeling, right? We're talking about an opioid. So again, I'm just gonna gloss over. Can you guys still see? I think you do all still see the poll. I think I can exit out of this. Hopefully you can't see it. And you just see this slide. So again, we're seeing increases in all regions for women diagnosed with primary and secondary syphilis who reported heroin use in the past 12 months. Let's go on. Let's talk about men that have sex with women. Again, increase in all regions. In the Midwest, we're seeing 125% increase in reported heroin use. And in the South, we're seeing a 71.4% increase in heroin use among men that have sex with women diagnosed with primary and secondary syphilis. And I'm just going to keep repeating that because I want you all to remember that this all is taken from the DIS interview. Okay, and now men that have sex with men, we did see an increase in all regions for reported heroin use. However, keep in mind, this was about a 1% increase in the regions. So really not a huge increase. Let's compare the two again. We're seeing very similar trends, both with an increase in men that have sex with men that have sex with women, and women reporting heroin use from 2014 and 2018. So let's go to the polls again. How do people use heroin in your jurisdiction? What do you hear in the field? What do you hear in your interviews? What do you hear in your community? Again, inject, smoke, snort, suppository, swallow. Some names you might hear for heroin in your interviews, you might hear smack, H, dope, horse, and some other names for suppository, you might hear ballooning. Another name for swallowing, you might hear parachute. Looks like 44% voted. Mostly injection use. Okay, so let me exit out of this poll. Some smoking, some snorting. And since several of you reported injection drug use as a method of use, let's look further into injection drug use by region. Okay, again, women's rates, we're seeing an increase in the Midwest and an increase in the South. Amanda will touch on that later on. And we're seeing an increase in all regions for men that have sex with women reporting injection drug use with primary and secondary syphilis. In the Midwest, we're seeing a 347% increase from 2014 to 2018. In the South, we're seeing a 53% increase from 2014 to 2018. Now, men that have sex with men, we're seeing an increase in the Midwest, and really relatively unchanged in the South. Again, why is this? These are the interviews that we're conducting more often, but yet we're getting less and less information. So let's compare the two. The only difference with reported injection drug use, aside from the increase in use from men that have sex with women and women, is that the Midwest is seeing an increase in men that have sex with men reporting injection drug use. So now that we know more about where and when syphilis and substance use occurs, how do we begin to intervene as disease intervention specialists? So let's start talking about partner services, and a quick background on partner services, or we like to call it public health follow-up in the Lone Star State. So we're going to talk about how we do it in Texas. So Texas is an integrated HIV STD partner services program. We're decentralized partner services, which consists of regional and local health departments, which those health departments serve 18 jurisdictions, 254 counties, and we have about 110 DIS physicians. And at any given time, we're around 80% staff. And like most of our colleagues are across the US, we have DIS reassigned to COVID. And during the peak, or the summer peak of COVID, let me say, there was around 70% reassignment of that field staff. So when we talk about central office, we have 4 public health follow-up consultants or partner service consultants, which I myself is a part of that group. And between the 4 of us, we do have about 100 years experience at partner services, if you can believe it. We have 3 project coordinators. Amanda Reich is our congenital syphilis coordinator. We also have a data to care coordinator, and we have a capacity building coordinator. We have 1 STD nurse consultant, an STD data or program manager. And then we serve a population of, at least in 2018, and it's growing, of about 28.7 million. Let me not say 280 million here. 28.7 million people that we are serving. And due to the size of Texas and the Texas Public Health Follow-Up Program, Texas DIS are trained here at home with a central office curated training curriculum. So we, instead of sending our DIS to ISTDI, is what you might hear, is we call it Fundamentals of Sexually Transmitted Disease Intervention, FSTDI. So I want to share with you guys some highlights from our FSTDI, which is a 5-day in-person course. And it's recently been redeveloped. It has not launched yet in this redevelopment, but we changed it to a 2-week, 40-hour virtual training. And in this training, we're going to lay the foundation for partner services interviewing. So on day 1, what we're going to do is we're going to be looking at judgment. We're going to be doing exercise to allow the DIS to practice suspending their judgment. We're going to get them comfortable with sex and drug jargon. We have exercises where they're laying out all the jargon that we know. We're sharing jargon that we know. This is to help them manage their discomfort. There's going to be phrases that you hear that you're not familiar with. How do you ask that client about more information about that jargon? We also, and this is all on day 1, we talk about the drugs that we frequently hear in interviews. So this slide from FSTDI is talking about methamphetamine. We talk about the AKAs, how it's used, the effects on the body, and how it interacts with sexual behaviors. Also, so that's all on day 1. On day 2, we talk about communication skills, barriers to engagement. Day 3, we're practicing interviewing. We're having the DIS interview their peers. Day 4, we're really talking about field safety. And then what we do at the end of FSTDI is we review the core values and beliefs to reinstate why we're doing this work. So at FSTDI, we address the power of stigma and how damaging it can be to our clients' health. We discuss checking our unconscious bias and judgment at the door. Stigma is perpetuated by verbal and nonverbal communication. So your thoughts are shown by what you say, what you don't say, and how you move. And let's not forget that our clients may experience competing social stigmas surrounding various social identities that are fixed when they come in through that door, such as mental health, race, sexual orientation, and age. And remember too, that our words matter, even our documentation and our notes. So everything that you say in that interview room should be person first language. And then when you go ahead and document in your database, you want to make sure those notes reflect that language as well. So the partner service interview is pretty standardized across the nation, but let's break it down like we do in FSTDI to see why the placement of each section is important to engaging the clients that use substances. and the clients in general. And remember, the comfort of the client may dictate the order of this interview. So we have the introduction, the patient assessment, medical history, disease comprehension, partner elicitation, risk reduction, and conclusion. So I know some of you on this joining our breakout session, our DIS, you're like, yeah, Danielle, I already know. I know the format like the back of my hand. So let's talk about how we use that format in order to build rapport. And it is very important to establish rapport early in the interview so the clients will be open about substance use, partners, and social needs. And so throughout each section of the interview, you'll have an opportunity to collect information about social needs. So let's talk about the introduction. This is your first impression. This is your opportunity to establish confidentiality and to ask the client about what their understanding of syphilis, HIV, whatever the bacteria it is or the virus it is that you're interviewing them for. So here you're going to state the purpose of the session, just like we stated the purpose of this breakout session, right? You're building trust with that client. You're telling them what your professional role is. You're talking about confidentiality, you're confirming their identity, you're informing them of their lab result, which may be very big news to them, and you're briefly explaining syphilis too. From there, what you're going to do is you're going to move on to the patient assessment. And this is your opportunity to make a personal connection with the client unrelated to the diagnosis. You're going to address the client's concerns about the diagnosis, but you're also going to go into social history where you're learning about where that person lives, where they've traveled. This is, sorry for the ambulance, I'm working from home right now. So this is your opportunity to say, oh, hey, oh, you lived in that, you lived in that zip code, I live in that zip code, or, oh, you traveled to such and such a place, I've been wanting to go there, how was it? This is your opportunity to really build a personal connection. From the patient assessment, you're going to go into the medical history where you're gathering additional information for referrals. So this is, hey, I know we're concerned about syphilis or HIV right now, but let's talk about prenatal care or getting you onto insurance, whatever it is that you can help them and give them additional referrals for. Next is disease comprehension. This is going to make or break your partner elicitation section. If you cannot relate to the client why it's important, why partner services is important, you're really not going to be able to intervene in the spread of that bacteria or that virus. So let's move on to that partner elicitation section. This is the most intimate section of the interview format. You are asking clients about their sexual history. You're asking them, how often you engage in anal sex and vaginal sex and oral sex. These are questions they may have never been asked before and may never be asked again. So you want to make sure that rapport is stable and already built before you get here. And then we have the risk reduction section. So even if we consider the client's behavior to not be in their best health interest, we need to respect the client's autonomy over their own actions, choices, and behaviors. Okay, so we're building a plan together with the client. Think about, condoms as not even a variable with this. And that's one thing we do in FSTDI. We have an exercise called A World Without Condoms. Let's take condoms off the table. What else can we do to help reduce our opportunity of coming in contact with another bacteria in the future? And then lastly, we have the conclusion, which is going to help us go over the agreements that we have with the client and establish and finalize that trust. Hey, let them know, be transparent. I'm going to call you again. For all of my DIS in the room, you know that you're going to do that re-eye. Let them know, hey, on Friday, I'm going to touch base with you after you're done work at 3 o'clock. This is just a way to solidify trust. And again, your introduction and your patient assessment is two of the most important sections of that interview format. This is the very beginning. This is where you establish who you are and what you're about. So let's dive into that patient assessment section. This is where you're going to get the social history, and this part of the interview is where the DIS collects the information on substance use. And that's the information that we saw presented on those graphs earlier. So we have the demographic section where you're asking them what race and ethnicity do you identify with, your residency, where do you live, how long have you lived there, your travel history, when was the last time you traveled, where did you travel, how many sex partners did you have while traveling, your hangouts, where do you go after you're done work, who do you hang out with, institutionalization and incarceration history, when was the last time you were incarcerated, if ever, and then we talk about the substance use. And why do we talk about, why do we even ask this? This is a question that a lot of the DIS have for us at our training. And really the drug use, particularly use of methamphetamine and injection drug use, is associated with sexual behaviors that increase the risk for acquiring syphilis and other sexually transmitted infections. And those sexual behaviors include multiple sex partners, concurrent sexual partnerships, inconsistent condom use, and exchange of sex for drugs or money, or a place to stay, which would be considered transactional sex. Note that drug use, especially methamphetamine use, can be linked to chemsex as well, where you have multiple partners. It might be a party, it might be group sex, and also it could also include polysubstance use as well. Okay, we know why, but how? What you want to do is you want to know the verbiage. Avoid medical terminology. If you're going to say, with syphilis, you could at one stage have alopecia, explain what alopecia is. They may not know. And don't wait for them to ask you. You say alopecia and say that, which could include patchy hair loss. Avoid DIS terminology. You don't want to call them and say, hey, confirm their identity, you've been diagnosed with 710, and I know no one's ever done that before. You want to use the language that the client is using. So for instance, if you're talking about drug use and they say, well, I slam, instead of saying inject, say, well, how often do you slam? And we want to be professional with this as well. You want to ask open-ended questions and allow for the conversation to flow. You want to prevent the client from shutting down and blocking you out. Oh, hold on, I lost the earpiece, y'all. Hold on, it's in my hair. Hopefully you all can still hear me.
We have stopped hearing you. Danielle? Danielle?
Danielle, can you hear us?
I'm not sure if Danielle can hear, but I can. Oh, Danielle, are you there? I think she's picking up the audio, but I can grab the slide for her while we wait. So one of the things that we want to make sure that we do is we want to ask the right questions. So how do we ask clients about substance use while Danielle connects to the audio is we want to make sure we ask these questions is where do you use, what drugs do you use? And one thing that Danielle and I both like to do is kind of go through the list. You might want to start with legal substances like alcohol or marijuana. Remember, marijuana is legal in several states now. How often do you use and how do you use, right? So we talked a little bit about injection drug use, and many of you reported that your clients use injection drug use. When we looked at those graphs, we saw that injection drug use had remained stable for MSM and MSW. And who do you use with? Who do you use with is a great question for us to get needle sharing partners or cluster opportunities. And when was the last time do you use? Is another great question we can ask. And where do you use is a great question for screening opportunities.
Amanda, can you hear me?
I can hear you, so go ahead and pick up and I'll mute myself.
Woo! I'm sorry, guys. I'm not used to these AirPods. And let me share my screen again. Please forgive me. And I heard Amanda going through each one of those questions. Remember, if she hasn't already, that who do you use with is an opportunity for partner and clustering, and where do you use with can be an opportunity for screening as well. Okay. So why do I have to enter this information into Maven or Prison or NEDS or whatever database that we use? And the reason for this is to strengthen the understanding of the rise in syphilis. So without documentation, we won't have the data and we won't be able to create interventions. So let me just share with you how we collect information in Texas. So Texas uses a Maven-based database for STI reporting. And many of these questions are required to be answered for CDC reporting. Several of these drugs, though, have been added to the Texas database. So we collected this information through trends that we were noticing in the field. So for instance, benzos is on here, nitrates and poppers is on here that you might not see on your own, inside your own database. Also, we have how we collect sexual behaviors. Again, this is an actual snippet of our database. So you'll notice a lot of these are similar to probably the questions that you're asking as well. Have you had sex while intoxicated or high in the past 12 months? Exchanging drugs, money, goods for sex in the past 12 months? Had sex with a person who injects drugs in the past 12 months. The only difference with this system is that it's actually capturing the type of sex. So if you put yes, anal vaginal intercourse, it's going to tell you, well, what kind of sex? When you were engaging in sex with that person who injected drugs, was it just oral? Was it just anal? Was it just vaginal? Was it all three? Also, if you notice here, I did want to mention, because I wasn't able to mention it earlier, have you met sex partners through the internet? So I just want to, I know this, that if you are DIS in the field, you've probably had someone say, well, I don't know their name, but here, this is their profile picture. There are certain lingo that people use on their profile that may indicate that they're engaging in substance use. So if you see TNP on their page, that stands for party and play, which means they could be using substances and engaging in sex. If you see capital T's everywhere, that could stand for Tina. So just know that that's, as we talked about earlier while we were polling, that's another word for methamphetamine. If you see ice cubes as an emoji, that could be an emoji for crystal meth. So just keep these things in mind when you're in your interviews. So now what we're going to do is we're going to circle back to national trends that we have been able to identify because of the DIS data collection in the field. Amanda, please expand on the substance use and the implications on maternal and congenital syphilis. And if you can take over that screen sharing.
All right, thanks, Danielle. And we, like Danielle said, we're going to circle back on some of the national trends. So I want to take your attention to this graph over here, and we're talking about 2018 cases of primary and secondary syphilis among women specifically. And we're looking at this graph because primary and secondary syphilis among women is highest in both the South and the West. So Danielle already showed us this graphic, but substance use among women diagnosed with primary and secondary syphilis has increased in the last 5 years. And we want to talk about methamphetamine use because nearly 20% of women diagnosed with primary or secondary syphilis reported methamphetamine use within the last 12 months prior to their diagnosis. And this was a 178% increase over the last 5 years. So that's a pretty dramatic increase. And we also want to kind of quickly touch on that Injection drug use increased nearly 180, injection drug use increased 87% since 2014, and heroin increased 71% since 2014. So those are considerable increases among women, and this is just primary and secondary syphilis. So when we look among the regions, when we're talking about injection drug use, as many of you reported, injection was the main method of substance use for both methamphetamine and heroin. And we're talking again among women with primary and secondary syphilis, that it has continued to increase in the Midwest, South, and Northeast. And injection drug use tripled in the Midwest since 2014 and doubled in the South. Talking about heroin use among women with primary and secondary syphilis, it has increased across all regions in the United States in the last 5 years. And again, in the Midwest and the West, it was about the same, around 8%, but heroin use increased 80% in the Midwest from 2014 to 2018, and 167% in the South. But your colleagues in the Northeast may have a different story to tell you, because it was an 800% increase in the Northeast since 2014. So methamphetamine, we're saving it for last because it is the highest reported substance use among women diagnosed primary and secondary syphilis, and it has risen in all regions in the last 5 years, but most especially in the Midwest, with the Midwest reporting a 559% increase in methamphetamine use. So women diagnosed primary and secondary syphilis are reporting methamphetamine use. So this is really something we want to dive further into. And in the South, we had a 273% increase in methamphetamine use among women diagnosed with primary and secondary syphilis. And so we're talking about diagnoses since 2014, and we just talked about methamphetamine, and we want to recall that that increase was around 2014. So the line on this graph here is women diagnosed primary and secondary syphilis, specifically those of childbearing age. And CDC defines women of childbearing age as ages 14 to 45. And you can see on this graph that that really is right here, right? So that's when we first see that increase in primary and secondary syphilis rates among women. And around 2017 is when we start to, or that's 2016, I don't know my years on this graph, 2016 is when we really start to see an increase in congenital syphilis cases. And it makes sense, right? When we have more syphilis cases among women, we're gonna have more congenital syphilis cases. And one thing that we know is that pregnant persons who report substance use are they are less likely to regularly attend prenatal care visits. And we hear from our clients that they do have a fear of involvement from Child Protective Services or CPS or criminal justice system, right? So Texas is working on a way to better collect that data because it's not available in our Maven-based data system. And so I'm going to show you that right now. So many of you guys you may be familiar with the congenital syphilis report form, known shorthanded as the STD-126, and we are optimizing our Maven database so that we can collect some of this information in there. But right now we use this STD-126 abbreviated form. And so sites with high rates of congenital syphilis investigations who also have high rates of completeness and accuracy in reporting do get to use this STD-126A, which includes some additional fields that we've identified as possible barriers to care engagement, and they may contribute to congenital syphilis cases. And so you can see on this form that we do have some fields like insurance status, housing instability, incarceration history, CPS involvement, and substance use is on here. And before we dive too much deeper, I want to talk about syphilis testing during pregnancy. And so this is a pretty important piece of congenital syphilis. So CDC does recommend that all persons should be tested at least once during pregnancy at the first prenatal visit. And pregnant persons with high living in high prevalence areas of syphilis or who are at high individual risk should be retested at 28 weeks and again at delivery. And so what is high individual risk? Like, we don't really love that word, but high individual risk means multiple prior STI diagnoses or recent involvement with the criminal justice system, substance use or abuse, housing instability, or some kind of transactional sex. So I'm bringing this to y'all's attention because Wisconsin is one of 4 states that does not have syphilis testing requirements during pregnancy, although this could vary locally in your municipality or county. And Texas is one of 4 states that requires testing at all 3 points during pregnancy. So the first prenatal visit, 3rd trimester, and again at delivery. And this 3rd test at delivery was changed in 2019 after our last legislative session in response to our rising rates in congenital syphilis. And so some people may say, well, Amanda, are your increased rates in congenital syphilis and syphilis among women of childbearing capacity because you guys are just testing more? Well, if we're testing more and finding more syphilis, that means that there's just more syphilis in the community. So why do we have this congenital syphilis? And we need to find out more about it. So Texas is doing case review boards, and we use the fetal infant morbidity review tools for our enhanced congenital syphilis case reviews. And we had 367 congenital syphilis cases in 2018. So we're unfortunately not able to review them all in depth. So we have these enhanced case review boards, and we have one in Houston, one in San Antonio, and one in Dallas-Fort Worth. And we are using this enhanced methodology to look at missed opportunities for disease intervention and possible barriers to care engagement. And these 3 areas do make up 75% of our total congenital syphilis morbidity. So our enhanced medical chart abstractions, these do look for a little bit more than the STD 126. We are looking for medical care prior to pregnancy, going through the full prenatal care chart, intrapartum and hospitalization care for both mom and baby, postpartum care, as well as pediatric care follow-up. We do a maternal interview. This is different than a partner services interview. We use the femur maternal interview format that we have modified to meet our local needs. And as well, we changed it to kind of be more open-ended and follow the DIS interview format. Danielle mentioned it's super important to establish rapport, and we're asking a lot of personal questions about interactions with not only the healthcare system, but mom's living situation. We're asking questions about domestic violence and substance use and a lot of social determinants of health, which we'll explore in a minute. As a group, we meet externally and review this case. I say case instead of individual because this is totally de-identified since we're meeting with external stakeholders and we don't want to talk about client level details. And then after reviewing this case, we look for community action items and we start kind of individual provider level education. We may have to reach out to a doctor and say, hey, you treated Amanda and you didn't follow the treatment guidelines. Or then we follow up with direct outreach. So looking at organization and facilities involved with the care of the client, perhaps they need to alter their standard delegation orders, or perhaps they need to change something with their electronic lab reporting. And that's an organizational change, right? So maybe we're talking to our local jails and we're saying, hey, is there an opportunity here to implement screening for pregnant persons within the first 48 hours of incarceration instead of waiting 2 weeks? And then we're looking at systemic changes. So last legislative session, you heard me mention that we were able to implement a final 3rd test at delivery. The legislature also implemented a pilot program to allow for the transportation of other minor children under Medicaid to improve prenatal healthcare outcomes. And that was the result of our Houston Femur group really lobbying the legislature and saying, hey, we noticed that prenatal care outcomes would be better with improved transportation. Our San Antonio Femur also implemented routine syphilis testing at pregnancy crisis centers after they noticed women would go to a pregnancy crisis center and then be delayed in entering prenatal care. So really quickly, I want to talk about some substance use by toxicology screen among femur cases from the last 2 years across all 3 of those programs. So you can see that so first I want to say that we reviewed 46 cases among 44 women, and we had 14 cases that had methamphetamine use, 14 again with marijuana use, so testing positive for THC, 5 with opioid use, 4 with cocaine use, and 2 with other. And the other was K2 and benzodiazepines. And many of these clients did have polysubstance use. And I just want to point out really quickly to be aware of your local CPS reporting laws and regulations. So in Texas, many of our clients that only engaged in THC use did not have removals of custody. So we have CPS safety plans. And we also have safe haven laws. So if I don't have other children in my custody or have other children in general, and I'm pregnant and I am seeking prenatal care but engaging in substance use, I can go to a medical provider and say, hey, I want to get into rehabilitation, and they will not report me to CPS. And lastly, I want to talk about some identified barriers to care engagement. So you can see the most common barrier to care engagement is that 35 of our 44 cases that we reviewed over this time period were living at or below the federal poverty level. We'll talk a little bit more about that in a second. 25 cases did have substance use, and 25 cases did have CPS involvement. 9 cases had intimate or domestic partner violence, and we also had 5 cases with criminal justice involvement during pregnancy, 5 cases with housing instability, and 5 cases with diagnosed mental health disorders. So really quickly, we had those maternal interviews. And so our maternal interviews, we don't get them on every case, which is unfortunate. We really want to hear the mother's voice. And that's where we're getting some of our domestic violence or intimate partner violence information. It's not always documented in the medical chart. And housing instability, the same thing, right? That's not always documented well in the medical chart, as most of you know, as STIs. One more thing I want to say about CPS and substance use is that in Texas, we're a low CPS removal state. So a CPS investigation may start, but less than 3% of CPS investigations result in a removal unless substance use is involved. And then that number goes up to 67%. So women who report a fear of CPS involvement, that fear is not unfounded. So social determinants of health, you heard me just mention that and talk about that. We're looking at that graph. And what does that mean, and how does that impact our clients? It's not just affecting our women diagnosed with syphilis, certainly not just impacting congenital syphilis. It's impacting all of our clients when they come to us, because economic stability is a huge factor, right? Studies have shown that income is the highest predictor of our overall health quality. It impacts our access to education and a quality education. It impacts not only healthcare access, but the quality of our healthcare access and the neighborhoods that we live in and our neighborhood and built environments. So do we have stable housing? What kind of grocery stores are available in our neighborhood, and our access to drugs and alcohol? What kind of schools are there? And that goes back to quality of education. And it also impacts our social and community context, right? Danielle's talked a lot about stigma, but how does your community feel about mental health, race, sexuality, substance use, criminal justice, law enforcement? And so we're going to take a look at some of those in a little bit more detail. So households living below the federal poverty level. And you can see that in the United States, the South is most affected by the federal poverty level. And the federal poverty level is defined as one person, their income is at $10,800, I believe, and I did check that. So households living below the federal poverty level, 5-year estimates in Texas, the teal color is 10% or more in the county. So you can see that Texas is pretty affected by this, by poverty. And in Wisconsin, it's the dark blue, where 10% or more of the county is affected, is living at or below the federal poverty line. And this impacts insurance status, right? If I am living at or below the federal poverty line, I do qualify for Medicaid, but there may be other factors impacting my Medicaid access. Maybe I don't have ID, maybe I have unstable housing and I don't have an address. And there are other factors that impact all of these things. And so when we look at this map of insured, Texas again has more counties that are uninsured besides Alaska. So when we're looking at this map for the top 20 states, the highest percentage of uninsured persons, unfortunately, Texas is first with nearly 18% of Texans who are uninsured. Congratulations to Wisconsin, because in 2018, nearly 95% of the population was insured. Now, we know, unfortunately, with COVID, that those numbers are not the same and that more Americans are uninsured right now. And so, with all of that in mind, Danielle, how can we prevent STIs by intervening at the individual level, specifically with our clients who engage in substance use? I'm not sure.
Okay, hold on. Let me get my camera back on. Okay. Can you all see and hear me? Hope so. Okay.
Yes, ma'am.
So, okay, let's talk about some interventions that Texas had. We encourage our sites to be creative with their interventions. For instance, we had a local health department purchase bleach kits with additional funding that they received. And this was to be administered to their clients that stated that they were involved in injection drug use, and this way that they can clean their works and clean their syringes. Texas Department of State Health Services also provided a Narcan training. And in this training, it was provided by the Texas Overdose Naloxone Initiative, and they actually gave out syringes and naloxone in case you're in contact with a client or you're interviewing a client who may overdose during the interview. We also encourage, especially in FSTDI, to partner with law enforcement and for the programs and the supervisors and the program managers. And this is to find out more about the localized substance use trends. It's also in our program operating standards and procedures that our DIS elicit and document contracts and timelines with clients regarding identified referrals. And we require programs to create and maintain a list of local referrals. So if you see on the screen, this is actually a snip from our database showing the different type of referrals that they should have on that list in their local area. And also, we want to keep in mind referrals for Hep A and B vaccine, especially for someone who reports injection drug use. We also have field work interventions. We require DIS to conduct field phlebotomy, so they have to draw blood in the field. Especially, well, now with COVID, these are going to be a little bit modified. We also, some of the regional jurisdictions deliver field therapy, so they're actually able to bring doxycycline out into the field. Again, this does not include pregnant females who test positive for syphilis, but they also can administer azithromycin, ceftriaxone. We can also, one of the field work interventions that we have is transporting clients. So the DIS are able to transport clients that don't have transportation to the clinic for treatment and testing. And remember to decrease stigma. I mean, I think this is one of the biggest interventions that we can do at home and in the office, you know, whether it's with your family members or your community or when you're sitting there with a client. And I really want to leave you all with this quote from an MMWR. So among persons who use drugs, stigma and mistrust of the healthcare system, along with other social determinants of health, so what Amanda stated, unstable housing, poverty, incarceration, lack of health insurance, these might contribute to decreased healthcare utilization and reluctance or inability to identify and locate sex partners, resulting in delays in diagnosis and treatment. So with that, we want to come back to our intention slide, and we want to say, stay safe, y'all, keep people healthy, and keep doing the great work that you've been doing. And if you want to learn more, here's a list of our references. And we just want to say thank you. Thank you so much for the opportunity to be able to present.
Thank you.
Can folks hear me? I was having some connection issues.
I can hear you.
Okay, perfect. Thank you so much, Danielle and Amanda. I'm not sure if that was heard, but really appreciate your wonderful presentation. And thank you everyone for your patience with our tech issues. I know it's virtual world can be challenging. Also want to thank you for your comments and questions in the chat. We really appreciate those interactions. We will open up a quick Q&A session. Raise your hand and we will unmute you. Okay. So do you have any advice for how to build rapport quickly over the phone, given that in-person interviews are not currently happening in Milwaukee due to COVID, especially when diving deep with drug use and transactional sex?
That's a great question. I know that I myself as a DIS really struggled with phone interviews. So one of the things I did, and Amanda, we worked together alongside each other while we were interviewing. Amanda would assist with interviewing, and she actually listening in on her helped me build my interviewing skills over the phone. One thing that I do want to say that I believe I think that would help is transparency. Hey, we usually do these interviews in person. I would really want to talk about this sensitive information with you in person, but because of COVID, I can't do that right now. You want to make sure that you're verifying the person's identity before you go into the interview. I've seen so many times you say, hey, you know, hi, I'm calling for Amanda. Okay, great. You tested positive for syphilis. You know, just the matter of getting that date of birth and letting them know that you're not going to disclose that information to anyone but them is important. Amanda, do you have any other suggestions?
I'm going to just tack on to what Danielle said during the presentation is you can still find ways to have rapport with a client over the phone and say, oh, okay, that's a 312 area code. I'm from Chicago too. And that, just kind of, are you a Cubs fan or a White Sox fan? And then kind of try and make rapport that way.
Thank you so much, Danielle and Amanda. Next question. Can you briefly explain the criteria that is used to classify your congenital syphilis cases?
Sure. So we use the CDC case criteria. So it's just the regular 2018 congenital syphilis surveillance definitions for congenital syphilis. So for probable, it's a woman who has been inadequately or untreated within 30 days of delivery, or the infant has clinical manifestations with a reactive RPR.
Thank you. Another question, what kind of cultural considerations do you take?
Could the participant clarify?
Yeah, so my name is Delilah. I work with the American Indian population, and I know that when you work with all minority populations, which I probably assume that you work with them, and just because of where the data is for like STD rates and also populations who are using drugs, but are substances. My question is when you're interviewing people, I assume that there should be cultural considerations or being culturally aware about the questions you're asking, because I mean, it's probably hard to build a relationship. And then there also is just the systematic barriers to building relationships with people of power. And I know that you may not see yourselves as having a lot of power, but when you're associated with a health department, there is a power imbalance there between you and your clients. So I'm wondering, do you guys work with interpreters if you're working with Hispanic populations? Do you guys think about how you're asking questions and, just kind of what kind of cultural considerations do you take when you work with people of color or BIPOC populations?
So we do discuss this a lot in our training of the DIS, especially if you're not bilingual, or if you have to use that translator line with the client, it can be extremely difficult when you're asking questions, especially in Texas, with a monolingual Spanish speaker who may not necessarily been born in the United States. I mean, we ask, how long have you lived in the US? I mean, that's a hard question to ask. It's a really hard question to ask when you're on the interpreter line and you're not really able to fully express it, that, you know, hey, we ask this to everyone. This isn't just something I'm asking you. But even then, so we do prepare the DIS with certain barriers that may occur on our end because of the way that we ask questions. However, we don't really prepare them with an alternative list of questions to ask. We just encourage them to build relationships with their supervisor and their program manager to say, hey, this question wasn't answered and this is why. So unfortunately, I think that's something that we can look into doing in the future for sure.
I think, Delilah, perhaps to your point, is like we do have, in Texas, we do have some political complications with ICE, and I serve at the pleasure of the commissioner, so that's about as far as I can go with that. But all of our counties, all of our jurisdictions that are along the border have Spanish speakers, so that is a huge benefit to us. And most of our programs have Spanish speakers so that they can conduct interviews with our monolingual Spanish clients. And we are lucky to have a really diverse DIS workforce in Texas. I mean, we do have 110 staff, so that is a benefit for us. But as Danielle mentioned, it can be extremely difficult to conduct an interview over the translator line.
Thank you for sharing.
Thank you, Danielle and Amanda, so much for your thoughtful responses. I do see what time it is, and we want to respect your time, make sure you get lunch. But if we did not get to your question, please feel free to reach out to us and we will work to get your questions answered. Also, please complete the evaluation that Aubrey just put in the chat. Again, you'll win if you complete it. There will be a code at the end that you can use for the Summit Challenge, and we just greatly appreciate your feedback. Like I said, we're heading into lunch. So the lunch break goes until 12:30. And for those of you that would like to partake in our Lunch and Learn session with Dr. Quilter, that will start at 12 p.m. and you can find the link in the agenda. Thank you again, and we will see you at our next session.